recipient of National Sushrota Award, Best Teacher Award by Rajiv Gandhi University of Health Science, and an honorary DLA by Transdisciplinary University. Dr. Muralidharan Sharma continued to inspire as a teacher, researcher, and visionary. Today, he will speak on Ayurvedic management of complications of diabetes mellitus. Let's warmly welcome Dr. Muralidharan Sharma, sir.
Okay, thank you. I hope I am visible and the screen is also visible. Fine. Uh, Thank you for the offer to be with you. Now, I am supposed to talk about my clinical experience of dealing with the complications of diabetes and their mainly the complications as such. Now, I will not waste much time in the introduction part, which you have already heard about. The current definition of diabetes, as per the WHO diagnostic criteria, is when the plasma glucose, that's resting fasting plasma glucose, is more than 126, and postprandial 2 hours plasma glucose is more than 200 in adults. That's considered as a diabetes mellitus as such. Or the recently added criteria is glycated hemoglobin being more than 6.5%. Now, there are some other variations in the presentations patient who will come with the abnormal glucose readings. Now, that's one of the important issues which we have to consider when we deal with the clinical patients. Some of the patients may have a fasting plasma glucose slightly raised than above the normal limit, but postprandial is within the normal limits. That's considered as impaired glucose tolerance, which is according to the criteria, they also have to be considered as a potential cases for the diabetes, and they are also prone for complications of the diabetes. Another alternative is, or another type of the patients presenting would be impaired fasting glucose level, where the fasting glucose level is higher and the that's more than 125, and prostaglandin also is higher, slightly higher than the normal. That's the impaired glucose levels. And the general criteria is if HbA1c range of 6 to 6.4% also is indicated of a developing diabetes mellitus. This is about the general patients from the point of view of diagnosis as such. Now, patients of diabetes coming to an Ayurvedic practitioner would be having a different set of presentation. From my clinical point of view, the spectrum of diabetic patients in my practice, about 5% of the patients are fresh diagnosis patients which are diagnosed by in my clinic when the patients are casually identified with the impaired glucose level where the patient may not have any other symptoms. Or and another group of the patients are patients who are freshly diagnosed, and they are diagnosed because of the patient may have some symptoms which could be suggestive of diabetes, like which we call as the diabetic stigma, like the frozen shoulder syndrome or maybe the balanitis and so on. That again constitutes about a relatively smaller percent. And another group of the patients who are on already diagnosed diabetes mellitus, who are already taking some modern treatment, but they are opting for Ayurvedic treatment. And that's also another group of the patients, around 5%. Now, when I say this 5% or 10%, that's about a rough estimate, not exact figures like. And another major group of the patients are who are known diabetics, who are taking some contemporary treatment, and they are sugar may be under control, but they have some complications of diabetes, and for that they are want to an alternative Ayurvedic treatment, and that constitutes another group of the patients. Another major group of the patients whom I see are patients who have a good glycemic control, but they may have the other accompanying disorders like hypertension, osteoarthritis, etc., and they may come for such conditions, treatment of such conditions, and the diabetes is already under control with other contemporary medicine. One another group of the patients, another major group of the patients are patients who have unstable diabetes with other diseases, where we may have to do something for the diabetes management also. One more group of the patients are patients who present with the chronic diabetic complications, which I will be dealing with, or patients with the gangrenes, that they also the group. Major patients of ketoacidosis or patients who want to have insulin dependent diabetes who want to have a replacement with diabetic treatment, they are relatively minor numbers. This is the spectrum of the patients which I see. It may be varying from a physician to physician. Some other physicians may have a different set of the patients. But one major group of the patients whom we see would be patients with diabetic complications and who want to have some Ayurvedic alternative treatment for these complications as such. Now, uh, again, my focus will be mainly on the issue of diabetic complications, how I manage and my approach to the patients of these complications of diabetes. But casually, how I deal with the other patients are patients who are just hyperglycemics, not really established diabetes. Either they are the IGT or the alternative or poor control, these FGTs. Like in such conditions, HbA1c assessment is important, and the majority of the patients they can be managed with the diet and lifestyle alone. And if the family history is positive, then we have to be more cautious. Usually, I don't prescribe any specific medicines in such patients, but if the patients who have a persistent hyperglycemia or certain of the patients who want to have some treatment, then I would be prescribing like drugs like Chandraprabha, Arogyavardhini, Rasayana Aushadhis, and then the Anulomana Aushadhis like Avipatikara. Vilachana is one of the important methods by which I have seen a good number of patients having the normal glucose level and followed by, of course, the diet and lifestyle care is important. There is no need of specific medical intervention is necessary. Only if the patients do not have satisfactory improvement, even after 3 months, then only the medical treatment is given. Exceptions are patients who have come for surgical treatment or some other acute medical conditions. That blood sugar level is an important criteria which we have to consider, and there I will be making use of all the available tools by which we can manage the patients as such. Now, patients who are recently diagnosed and opt for Ayurvedic management, this is one of the rather critical issues. Many of the patients may have just the curiosity to see like what's Ayurvedic treatment, and they may not be in a position to sustain the treatment for a long time, and hence most of the times the follow-ups are quite significant. And but still, in such patients, the first of the thing is you have to screen for the complications like neuritis, vascular pathology, albuminuria, and cardiovascular status. And if there are no other complications, my prescription would be usually again, I will not start with the medicine in the beginning. I will be advising diet and exercise for 1 month and follow up and see if the patient responds properly or not. If this relation also is one of the other alternative tools, the benefits once the patient has become established diabetes, it's not the IGT or FGT. Once the patient has established diabetes, the Virecana advantages may not be very consistent. Some of the patients may respond very well, some of the patients may not respond very well. So that's the issue. If the patients have some risk factors and the patients are already established diabetes, my prescription usually would be Asanadi Chandraprabha Arogyardhana, Asanadi Kwarta acid. Then patients who are already in on medical management and have a satisfactory glycemic control, somehow they want an Ayurvedic alternative treatment. It's all if everything is fine. I will not suggest the patient to shift over to Ayurvedic treatment. Stress on the lifestyle modification, and if the patient insists, then only we may just start with Ayurvedic treatment. And usually, my prescription would be Asanadi Chandrapura Arogyardin Jasadavasma and Ongasma. One important is if the patient becomes not, his glycemic levels are normal, we will not withdraw this contemporary medicine immediately. The contemporary medicines can be withdrawn gradually, sustaining the blood sugar level. Then only the patient can be switched over from the contemporary medicine to Ayurvedic medicine. But here also, most of the patients would have some this issue on prolonged treatment, and these follow-ups or lapses are more. Now, that's about the general spectrum of the patients of diabetes. Now, the focus of today's discussion is about the complications of the diabetes. Now, when we say the complications, In the present terminology, complications are the symptoms which are produced after the presentation of the disease. But when it comes to the question of the cutoff level of diagnosis of diabetes mellitus or a prameha, based upon our samhitas, where you do not have, where Charaka or Sushruta didn't have the facility of assessing the blood sugar level, or blood sugar level was not the basic criteria of making the diagnosis, and the criteria was of something different, where the patient would have a clinical presentation of set up the symptoms of the abnormalities of urination and so on. Whether these symptoms presented or described in our samhitas, they have to be still considered as the Pururupa or they are the complications. These are the issues. I would say many of the patients of diabetes will present exactly with the same symptoms which are mentioned in Charaka, like Svedvangagandha, Shitilangata, Shayasana, Sukno Sukera Nishta, Surnirta Jihva, Shravanopadeho, Ghanangata, Kesana Khati Vriddhi, Shisa Priyatum, Galalalushosha, Madhavyam Masya Karapadalah, Bhavishyato Mehagadasya Rupam Mutre Abhidhavati Pipilikacha. These are the symptoms which are mentioned in the Samhita, and all of these symptoms exactly are true. Whether they still have to be considered as prodromal or many of these symptoms are serious of the complications, that's the issue. I would not go into that fine discussion of whether they have to be considered as a prodromal or not. Many of these symptoms are now considered as a complications because the cutoff level, the benchmark for the diagnosis of prameha and the diagnosis for the diabetes mellitus, they are different. The cutoff benchmark for diagnosis of prameha is based upon the Prabhuta Abilamutrata, whereas the present level we have a very definite, very objective the blood sugar criteria level, and hence we will not go into that threadbare discussion, threadbare or rigid statement of whether they have to be considered as Pura Rupa or the complications. But many of these are the complications. The established complications of Prameha as which are really mentioned as the complication, the upadrava, are avivako arachishchadhi nidra kasasapena sah upadravaha prajayante mehanam kavajanmanam. Now, these are also the real complications which we see. We may make use of a different terminology in the current situation, but the complications remain the same. Similarly, all the other complications, basti meha nahi hote laha, mushka abadaranam jwaraha, laha trishna, amlika, murcha, vidbhela, janmanam, all these are the specific complications which are mentioned. Now, whether these complications are can be translated to the present terminology and with the contemporary protocol and approach to the diagnosis, considering the interest of the patient, how we can manage, how we can modify the treatment. That's exactly the point which I am just highlighting. And as I deal with the patients, right now, from the contemporary point of view, complications of diabetes are categorized into acute complications like diabetic ketoacidosis or hyperosmolar hyperglycemic status, which is due to the abnormality of the osmolarity produced due to persistent hyperglycemia, which are acute conditions, or patients who have hypoglycemia. Chronic complications are again categorized into microvascular and macrovascular complications. Microvascular, they are retinopathy, neuropathy, nephropathy. Macrovascular, cardiovascular, or peripheral arterial disorders, and other complications like food complications, infections, etc. Now, I'll be just dealing with the common conditions which we deal with in the situation of an Ayurvedic practitioner, how we deal with that. Now, from that point of view, the most important and the most common complication which we see in patients of diabetes are the neuropathies. Neuropathies are the most common complications affecting almost 50% of the patients as per the current literature. And one important thing, about 7.5% of the patients may also have the symptoms of neuropathy by the time the diabetes is diagnosed. Karapalalaha, which is mentioned as a Pura Rupa by Charaka, whether this has to be Pura Rupa or Upadrava. In 7.5% of the patients, it is a Pura Rupa. In others, it could be the Upadrava. Now, that's how we may just go for the debate, but I think I will not, that's not the important issue. The risk factors for the neuropathy are Patients who do not have a proper glycemic control. One of the most important issue in all patients of diabetic complications is the poor glycemic control and advanced ages, hypertension. If the patient has a long duration of diabetes, then the chances are more. Patients who have altered lipid levels, smoking, alcohol intake, and patients who have a tall height, they also have these symptoms. Again, they are categorized into three sets of categories: sensory, motor, autonomic. Sensory is usually presented with the altered sensation. Either it could be reduced sensation or it could be hypersensitivity, where the patient may have pin and prick sensation. The most common is reduced sensation, and again, most frequent area is involved is in the lower limb. And typically, the areas of diabetic neuropathy, sensory neuropathy, are mainly in the lower limb extremities, and the very common symptom, initial most symptom, the patient would say like patient feels as if he is wearing the footwear even when he is not wearing the footwear. And the extremities are more frequently involved. A sensory and motor together. Very often it's more towards the core part of the area, towards the thigh or maybe over the upper part of the abdomen. These are the areas where the patient may have a altered sensation as well as movements may be slightly diminished or patient may have a rigidity. Then pure motor neuropathy, where the patient may have impaired movement, the or contractions of the muscles, where the patient may even have that trigger finger-like symptoms due to the initial motor sensory pathology, or there even it can lead to the atrophy of the muscles. Usually, it's again in the extremities. Autonomic is related to the abdominal symptoms, abdominal areas, the sensory autonomic nerves, parasympathetic and sympathetic. And I would consider this pathology, pathogenesis, as a pitta vyana. The symptoms are daha, gatra vikshepanam kramaha, stambanaha, dandakashchapi, all that mixed together, whether sensory or motor, stambana and dandaka are the motor, and the daha is the sensory symptoms like. The sensory neuropathy symptoms usually are presenting with numbness or loss of feeling. Usually that's the same. Even occasionally it could be pain like carpal tunnel syndrome or extreme sensitivity or skin may be cracked. That's exactly Karapadeyo Hudaha, Suttara, etc. And in such conditions, of course, all primary approach of the treatment would be glycemic control. Diabetes has to be controlled whether you use the contemporary medicine or whether we use other medicines like asanadic vata or so on. In addition to that, patients who have a sensory neuropathy, my prescriptions would be Smilsagarasa, Chandraprabha, Ashwagandharishta, or Dashamula Nirohabastri. Patients who have the impaired or pain sensation more, they will respond much better. Who have impaired sensation like numbness, their response is poor as such. Patients who have either pain or extreme sensitivity, they respond much better to our protocol of the treatment. Whereas patients who have a impaired sensation, the response is poor. Motor neuropathy patients would always have muscle weakness, reduced reflexes, difficulty in maintenance of balance, and then again it could be either the distal or proximal areas, Shitilangata, Svedo Angagandaha. In these conditions, my treatment would be Ekangavira, Abhrakavasma, Tapka, etc. The Basmas Rasayana Aushadis, and then Rajayapanabasti is given. Response, again, of course, in all these patients, one basic issue is control, glycemic control. That's one of the important issue, which I will not repeat again and again. The response would be not so very dependable. But definitely, yes, compared to the contemporary system of medicine, where there is virtually nothing to, or very little to be done in case of the muscular motor neuropathy, except for the protection and the local palliative measures. Our treatment would give somewhat better satisfactory results, though this may not be a complete cure. The next variety of this neuropathy is the autonomic neuropathy. Autonomic neuropathy again may present with the digestive symptoms or urinary or cardiac or sweating, abnormality of sweating or pseudomotor symptoms. The avivagaha, aruchihi, chandi, nidra, which again they are categorized as the Upadrava. In these conditions, my prescription would be patients presenting with the digestive symptoms. The Agnitundi, Arogyavardhini, Avipattika Churna is the usual prescription. Vilachana also helps. Urinary symptoms, of course, the same medicines, Chandraprabha may be added. With the cardiac symptoms, of course, there is a need to evaluate the cardiac functions completely. And if the patient has involvement of the coronary artery as such, then the treatment protocol would be completely different. The only additional treatment which I may prescribe would be Prabhakaravati, Ayurvedic part. But the evaluation of the coronary artery and the circulation in the myocardium is quite important. Once the patient has been, that cardiac functions have been stabilized and the rhythm is somewhat maintained, which we may need some support from the contemporary system of medicine, I would be prescribing Prabhakaravati in such patients, which may help to a certain extent. But that's not an area where we can say like our treatment would be very effective. Sweating and abnormalities of the sweating is another of the symptom. Usually that is responds very well to Vivechana as such. Now, one more of the most important area of the diabetic complications is the prameha piraka or diabetic ulcers and diabetic infective complications peripherally. Now, diabetic ulcers or prameha piraka, they are produced due to the combined arteriopathy and neuropathy. That's exactly our margatpag shesha dadavana apyayante, the Avrata Margatva, the blockade of the vessels is the most important thing. And the Prameha Pilaka are very well described in our Samhitas. Approximately 6.2% of diabetes in India, diabetic patients in India, would develop diabetic foot ulcers, and most of them overall the lower extremity amputation rate is around 31% of diabetic foot ulcers. This is the contemporary system of medicine. Now, I'll come to that part like how our treatment would be somewhat different. Ayurvedic treatment would produce a different result, and what is the difference? And that's one of the area where we have a definite advantage. So I will be going a bit in detail about this. The current approach of diabetic ulcers, the classification would be again the common type of the complication is a Wegener classification, where depending upon the depth of the ulcer, they are categorized into 5 grades. Grade 1 is very superficial ulcer, and uh, the grade 5 is extensive ganglion involving the whole of the foot. And usually, grade 4 and 5 are considered as a gangrenous ulcers. Or there is another method of classification, Texas classification. Texas classification is through assess about the presence or absence of the infections, where the patient may have a ulcerative lesion with complete newly epithelialized, new epithelium has developed. But if there is no infection, then it's only A. If there is an infection, it's B. And if there is a ischemia, also, then C. Infection and ischemia, both of them are together, then the D. And usually we depend upon this Texas classification to specify the severity of the disease. The depth is considered with the 1, 2, 3 categories, and the presence of other complications A, B, C, D. And this classification is more vital or more frequently used. Now, this has a relevance when we go into the issue of the Prameha Pilak as mentioned in Sushruta also. Of course, it's a same issue presented in the form of a diagram, the grade 1 to grade 5. Now, with this background, if you read Sushruta Samhita, the Prameha Pilakas, they are categorized as the Sharavika, Sarshapika, Kachapika. Most of the times, the students may have a confusion with these names as such. Dashapidakaha, 10 varieties of them are named. And the incidence is more in the extremities or in the areas where the fat tissue is thick, like गुदे हृदि शिरस्यं च पृष्ठे मर्मञ्चोत्थिताः सोपद्रवाः दुर्बलाग्नेः पिडकाः परिवर्धयेत्. Then virtually the name of Madhumeha comes in once the patient has a Prameha as such and the Pidakas as such. And these are produced due to the defects of the vessels, Rasayana, Daurbalyatra, the issue as such. Now, from this comparing what Sushil has said with the current terminology, I would be considering these Sharavika, the Sharavamatra Tadrupa, the deep-seated ulcers with the pronounced sensory neuropathy and deep ulcers, grade 3 and 2.3b based upon the Texas classification, grade 3, the Wagner classification. Such ulcers, they are exactly the Sharavika as such. In these conditions, the treatment is the patient has to have a X-ray necessarily to rule out the involvement of the bones. Osteomyelitis is quite common in such conditions. And if there is not much of a significant involvement of the bones, then pruning of the edges is crucial. And I would be advising Triphala Quadripalisheka, Jatya Ditela, and Shara application often in fibrous wounds which can produce a significant change in the course of the disease. It may some of the conditions may heal if there is no involvement of the bones also, provided the diabetes is well under control. So control of the diabetes is one of the issues, but in addition to that, these are the approaches. But essential is to rule out the involvement of the bones. If the bones are involved, then virtually the condition becomes incurable. But still, with the Tripura Quadriparisheka and Jatatela, patient can be managed somewhat better without any acute complications. Then Sarshapika is where there would be multiple eruptions. It's a superficial carbuncle with cellulitis, which according to our Wegener classification would be grade 2 to 3B and Texas classification 2BC, B or C. Because of the rapidly spreading condition, the condition tends to spread rapidly. Carbuncle, once this condition presents, it's having a very rapid spread. Patient would be usually toxic, high degree of fever, total leukocyte count also may be very high. In such conditions, in addition to mention of the diabetes mellitus, managing the diabetes mellitus, a course of antibiotic may be necessary. Most of the times it may be required because the patient would have a severe systemic toxicity. It's better to wait for a conservative treatment. But once there is a need for intervention, surgical intervention, it requires a wide excision. If you interfere, simple conservative approach or just handling here and there would not be enough because it may produce extensive damage, rapidly spread, and hence the treatment has to be wide excision if there is a physical intervention. Some of the patients can be managed without the physical intervention. Conservative approach wait for the patients to improve. Then the next is the Kachapika. Salaha, Kurma Samsana, Jnaya Kachapika Buddhi, which I would be taking these patients into the current category of vaginal grade 3 and Texas 0 to 1B. Carbuncle with the deep collection and the patient have a relatively systemic toxicity. The advantage is in this carbuncle, the area is localized, the area of inflammation is localized. It may not just spread as rapidly as the initial, the variety, the acute carbuncles like, because of the collection of the pus. In these conditions, again, the white excision is necessary. The whole area has to be excised and the wound has to be kept open and patient can be managed with Tripalaquata, Nimbagalka and Datallela, provided the diabetes is well under control. Then the Binata is a Mahati Pirakanila. Again, it's a carbuncle. Now, from the current point of view, it's a carbuncle. But when it's grade 4, as per the Wagner classification, Texas 2CD, in these conditions, carbuncle would have a poor vascularity necrosis. In these conditions, wide excision is a must. The whole area has to be excised. Without excision, it cannot be controlled. And once you have excised, the same wound can be managed with the same Triphala Quarta, Nimbakalka or Jatya Taila. That's the usual prescription. Then Putrini is where Mahati Alpachitagneya, where there would be an extension of a carbuncle, one carbuncle, and then there is a nearby area, there is another carbuncle or sequence of such carbuncles tend to occur. And in these conditions, it's usually the prognosis is extremely poor, which is grade 4 and Texas 2D. The prognosis is extremely poor. Wide excision is absolutely necessary. And the other effective, very energetic management of the diabetes and the infective complication is necessary. Then a carbuncle with the pyogenic infections, where there is first really liquid, first acid, but it's not spreading rapidly. That's the allergy. Rakta sita spotavati dharana to allergy bhavet, which is a relatively lower Texas grade, higher Wagner's grade, grade 3 to 4 Wagner's, Texas 2 to 3, and the complications of infections, localized infections are there. Because the pus is freely seen and it can be drained out, simple drainage would be enough. No need of wide excision, and this has a somewhat better prognosis. And then other local management would be same. Trifluopathy parisheka, nimbakalka, or Jactella would be the usual prescription. Then a fibrous carbuncle, a carbuncle which was usually treated with antibiotic without proper drainage. This is one of the issues. Some of the patients would have this kind of a presentation where the patient have a acute carbuncle which was not handled by either drainage or excision, but the patients are given antibiotics. The whole area becomes somewhat harder, persistent, and with the recurrent repeated extensions of the lesions, such is the Vidalika. So Vidalika, because of that indurated firm swelling, it is called as Vidalika. In these conditions, the is a complication of antibiotic therapy. Drainage is absolutely essential. We will have to make a wide incision, drain the area, and then, of course, the same treatment would be enough. The patients with the gangrene, Jalini, that's where there will be extensive necrosis and the necrosed tissue forms a scab. You can see that extensive scab. That's Mamsajala Samamrta. And in these conditions, the better treatment is, of course, takes a Wagner grade 5 and even Texas grade 4 or 3D. Debriding is one of the best options. Conservative is necessary. Amputation, it depends upon the patient's chances. Most of the times, amputation may be required, but with our treatment of triple quarter cleaning and jataditela, many of the patients, amputation can be avoided. Maybe your local debridement would be necessary. Very conservative debridement can save the limb of the patients. And that's one of the major number of patients whom we get in our clinic conditions. Then another relatively minor complication is the Masurica, septic folliculitis. Small areas of pus accumulation at the base of sweat glands. That's Masura samsumstvana gnayasa Masurica. In these conditions, again, which is a grade 1 or 2, and Texas AB, conservative drainage is necessary, and cleaning with trifluopathy would be enough. Not much of an issue. It's a relatively minor issue which can be easily treated. Vitrerica is where there is a deep-seated abscess, diabetes with the cellulitis and abscess, which is again the Vitreric Lakshanihi Yukta, Vitrerica Budhihi. It's this Wagner grade 3, Texas 0B, where abscess is seen. Of course, simple drainage is necessary, provided the diabetes is well under control and the limb doesn't have ischemic pathology. This can be effectively managed with our conservative management as such. Then, bullous disease of the diabetes, one more of the condition where the patient may have multiple bullous eruptions, which is quite troublesome. In these conditions, local care is necessary. Kamaruga or Khadira disturb because of the prickly involvement. I would be describing this. This also is a category of Bidrika. Then, in general, without going to the specific, the one of the most effective management in case of diabetic ulcers, which I would be always prescribing, would be Trifala Prisheka, cleaning the wound with Trifala. Once the patient's diabetes is controlled, systemic toxicity is controlled. These are the two other factors. A local management among all the different options, I would be considering Pipilaquata as one of the most useful option of the treatment in case of diabetic ulcers, which helps in maintenance of the hygiene as well as having a proper improving the vasculature. Patients respond very well. Many of those patients who otherwise might have been traveling for years together, they may respond very well to Trifala if we selectively prefer this, considering the status of diabetes as such. These are certain of the images of the changes which you can see, somewhat very excellent changes. Day 1, day 7, the whole area of slough has been cleared as such. And then, of course, the sequences like where it can be gradually healing. Uh, Nimbakalka also is another of the option when there is more of slough hard tissue. The Nimbakalka is better to remove these, and that again it helps in that somewhat conservative debridement. Rather, it acts as a somewhat conservative debridement, which also is one of the very dependable options. Kshaраkarma, in case of fibrous ulcers, Kshaраkarma can be one of the issue, but Kshaраkarma will help in the removing the fibrous tissue initially. So next day, the whole area will be more inflamed, reddish, but there will be a second option of healing. The next time, maybe after 2 or 3 weeks, there will be a healing process starts, and that the Trifala has to be used. So these are the main three uh, these strategies in case of diabetic ulcers. Then to improve the circulation, one of the option in case of diabetic patients with the ulcers as well as arteriopathy, the arteries are involved, microvascular pathology. In these conditions, I would be always preferring the Manjastalic Sharabasti as the option of the treatment. Manjastalic Sharabasti is one of the option of the treatment which gives a significant improvement in the circulation and helps in better healing. See, you have a patient with the necrosed toe, which was spontaneously amputated, and after a course of Sharabasti, you can see somewhat vascular healthy stem, which may heal better. So, combination of these would be Tripurapata, Mandestalik Sharabasti, or uh, this Nimbakalka, or maybe Kshara. We can manage many of those very complicated, very disastrous looking uh, diabetic gangrenes, and we have a good image of conservative debridement and credit of saving the limbs. Many of those conditions where amputations were suggested or recommended strongly, we could avoid the amputation. So limb saving is one of the major advantage of this advocate approach. And this is one of the area, diabetic ulcer is one of the area where our Ayurvedic approach of the treatment, the conservative approach of the treatment, would be really a trump card rather produces very significant changes in outcome if we are using it judicious. Then certain of the other complications which we can manage to a certain extent would be arthropathy, Charcot's arthropathy, that the patient would have continuous pain and the deformity of the foot. Patients, the bones also will be having ischemic changes, and the patient becomes totally debilitated. There will be significant amount of the pain. In such conditions, of course, that physical support with maybe the splints is necessary, exercises are necessary, and the Google Chandraprabha and Apple obviously produces a satisfactory relief. I'm not saying that it's a get sure. Patient would have a satisfactory relief in the symptoms, and the quality of life can be improved. Now, one more set of the complications are the renal complications. Among them, the microalbuminuria. Every patient of diabetes has to be screened for the microalbuminuria, and the prevalence is quite high. Majority of the patients would have the albuminuria initially, and then as the condition progresses, it becomes a chronic renal disease. So, early stage identification is important. Risk of microalbuminuria will be more when the patient has a hypertension. So if it is a diabetes mellitus with the hypertension, the risk will be higher. Even in the patients who have a minimal glucose metabolism abnormality, slightly altered glucose level, they also have a risk of developing microalbuminuria, and this even again hypertension is an additional factor. So in these patients, of course, all that issue which we have discussed in the beginning, like the protocol of diet, exercise, and if necessary, the specific Ayurvedic treatment. But for the dealing with the microalbuminuria, I would be preferring Chandraprabha, Punarna Mandura, Amslarista. In good number of patients, it can help in resolution to a significant extent. The presence of albumin level and chances of the patient going into this diabetic renal disease, chronic renal disease, would be again if the quantity of albumin secretion is less than 30 milligram per day, then either it's considered as normal or simply not this hyperfunction of the kidney or hyperfiltration. In such conditions, if it is less than 30 milligram, then it's better to have the glomerular filtration rate study. And if the glomerular filtration rate study is higher, then it's a hyperfunction of the kidney. If it is normal, then it's the normal as such. In such conditions, you don't have to do much. Most of the patients can remain in these categories up to about 5 to 10 years. If the patient has a high blood sugar level and the albumin secretion is 30 to 300 milligram per day, for all albumin patients, it's important to have 24 hours urine output studied and the albumin levels are it's considered as a incipient nephropathy. It's a possible nephropathy, and a good number of patients come at that stage. And in these conditions, up to this condition, we can manage with our drugs like Chandraprabhu, Punarnamanda, Amglarista better. Usually, on an average, these patients would be up to 10 to 15 years of diabetes. If the patient has a history of diabetes for 10 to 15 years, they may be maintained in this level uh, with supportive treatment. Once the patient has a overt nephropathy, that's where the quantity of protein loss is more than 300 milligram, and the GFR is reduced, it tends to reduce, that becomes a definite nephropathy where the other renal care treatment, contemporary treatment like maintenance of the electrolyte balance, managing the hypertension very effectively would be necessary. And simply our treatment, standalone anti treatment, may not have very satisfactory results as such, and these patients are really having a high risk of progressing into a stage where the dialysis would be required. And on an average, it's around 15 to 20 years of diabetes that would be developed. Then end stage renal failure is where the glomerular filtration rate comes very low and the amount of protein loss is very high. Then you need to have the end stage renal pathology where the supportive treatment like hemodialysis would be necessary. And it's usually, as per the statistics, 50% of patients with diabetes of more than 20 years would always end up with the nephropathy. This is the usual issue. Now, as far as the protocol of management and the diagnosis is concerned, diabetic nephropathy, see that classification of albuminuria, microalbuminuria, and nephropathy is quite important. When we say nephropathy, there is a definite these parenchymal changes in the kidney and the glomerular filtration rate is reduced, hypertension is essentially necessary, persistent albuminuria of more than 300 milligram is the confirmation of this. Usually the patient present with the symptoms of swelling in the ankles, feet or face, urination is very frequent, particularly at night. Patient may have foamy or bubble-like urine, which again indicates the protein, fatigue, loss of appetite, nausea or vomiting would be the symptoms. And in all these, and the patients with the chronic renal failure, where the patient would be having a very poor level of the urinary output. Even biochemical functions of the renal functions, like creatine level tends to rise. In such conditions, the is a end-stage renal disease where a supportive treatment would be necessary and essentially dialysis. In Indian situations, every year about 2.2 lakh new patients of end-stage renal disease added to the list of the dialysis patients as such, and on an average 3.4 dialysis every year is being done. So that's one of the issue. And most important part is early identification and prevention. What I have identified is if we can identify the patients of microalbuminuria, start with our treatment of Chandraprabha Punarnamandura, the possibility of renal failure can be postponed. But if the patient has a creatinine level of more than 6 milligram, In such conditions, again, our treatment may not help in reversal. At least we can pull on that there can be more time gap for the onset of dialysis in such patients. Even in the patients who are on dialysis, the same treatment protocol given in addition to all that contemporary treatment can help in reducing the frequency of dialysis to a certain extent. Though it may not be possible to manage the patients with a standalone Ayurvedic treatment. I don't suggest a standalone Ayurvedic treatment once the patient results in the nephropathy stage. But we can produce some changes in the course of the disease with our treatment as such. The other microvascular and macrovascular complications, which are already I have just covered up with the ulcers, the other complications are hypertension, atherosclerosis, coronary disease. The usual main prescription would be Manjistalic Sharabasti, Kaishora Gukulu, or Manjistalic Pata internally. Then one other area of very high risk issue and where we have very little to do is the retinopathy. Patients of around 16 to 10% of diabetes patients would have a nephropathy. Diagnosis of nephropathy is quite important with the fundoscope, and they are retinopathy. Retinopathy is categorized into the first stage where there would be only superficial changes, then macular edema, new vascular formation as such. Fibrosis also can occur, which can significantly impair the vision. And in these conditions, from as far as I consider, our there is virtually no definite curative management from the pharmacological point of view. The intervention, surgical intervention by ophthalmology practice would be essential. So I would always recommend the patient go for that intervention whenever there is a need for that, particularly if the patient reaches the neovascular stage or hemorrhages. Hemorrhages, they can result in acute visible loss, vision loss. But still, I would be advising the patients Triphala Churna with Madhu and Gata at night, Triphala Madhu Sarpibyam Nishi, Netrabalaya, the option. But it's not a very dependable therapy. I don't say that you have to depend upon only this. The current ophthalmological interventional care would be absolutely essential. There is no question of any medical treatment. Then acute complication of pseudoacidosis is one of the conditions where the approach to the treatment is basically correction of the fluid loss with the intravenous fluids, and hyperglycemia with insulin is absolutely necessary. I don't say that we can manage with only with the Ayurvedic treatment. And Charaka has considered this as a asadhya where the patient would have Vatulbana, severe abnormality of Vata, and patient already has become Atikarshila. In such conditions, the prognosis is extremely poor, and the only option is fluid and electrolyte balance has to be maintained, and sugar level has to be managed. So that's which requires a contemporary intervention, which may not be possible to manage only with the Ayurvedic treatment. Then another of the acute complication is the hypoglycemia. Again, it's categorized into three levels depending upon the severity. When the glucose level is less than 70 and about 50, somewhere in between 70 to 54, it's level 1, where the patient would have slight symptoms like sweating, maybe slight abnormalities, anxiety, etc., which can be easily managed with some food intake. Some glucose, either it could be glucose or food as such, which will provide enough support. If the glucose level goes less than 54 milligram, then a oral glucose supplement often may not be enough. You may have to administer glucose intravenously. And if the patient has a severe level 3, where the patient would have significant mental confusion or even loss of consciousness, there again it has to be administration of the glucose as well as maintenance of the electrolyte balance. That's in summary about the common complications which we see and how we manage. One important fact is the incidence of the complications are more if the duration of the diabetes is longer. Even if the patient is managed well throughout, still longer the duration, the chances of complications are more. If the patient is not managed properly, if the sugar level is not managed properly, the complications tend to occur. The pattern of the general pattern, statistical inference of this pattern of the complications of diabetes and duration of the diabetes. Like having more than 11 years, patients may have multiple complications. It's not only single complication. Though during our discussion, we have discussed about each of these complications as a separate entity. In a practical situation, patient may have multiple complications where the whole approach to the treatment has to be modified. In addition to these complications, the other issues are other common coexisting disorders, which are not really identified as a diabetic complications, but most of the patients of diabetic patients will have mellitus, the skin irritation in the penis, which can respond to well to Gandhakarsana, Khalirarista, and local hygiene, of course. Frozen shoulder syndrome, where the patient may have pain, avabahaka-like symptoms, the patient will have pain, and capsulitis, the whole capsule would be inflamed. They also respond well to Gokshali Vishamstivati, provided the diabetes is under control. Fatty changes in the liver, they respond to Aragyavardhini and Kumaryasava. Osteoarthritis, the usual treatment, the Gokshali Chandra Prabhavati. Patients having impaired sexual activity, though the response is not very dependable, some of the patients respond well to Makardhvaja treatment. Sleep disorders, mood swings, these are the other issues, psychological issues, where Simsagar and Saraswati can be prescribed, but I don't say that that would be alone would be enough to manage the treatment. Another of the common issues which we deal with in Ayurvedic practice would be adverse effects of the oral hypoglycemics. These are not I'm not saying the complications of the diabetes treatment. And many of these patients, they come with the established diabetes, under treatment, sugar is under control, but they have developed the complications of these. In such conditions, the patients have to be shifted over to the other options of the treatment. And the common complications, again, I'll be very brief about these issues. The sulfonylureas often present with the GIT symptoms like burning sensation, flatulence, impaired appetite. Meglutinates like repaglutine, they produce a hepatic or renal symptoms. And biguanides, usually weight gain. Triazolamides, they usually cardiac symptoms, edema tend to occur. Hepatic involvement in case of the glucosidase inhibitors like glucose and sitagliptin-like drugs, GAT involvement. The dapagliflozin-like drugs, renal involvement. These are the common issues. In these conditions, the option of the treatment is, if possible, we can switch over to Ayurvedic treatment with the same issue like the sugar has to be maintained. And these modern medicines also have to be changed depending upon the patient presentation, which is a very rather big issue, rather complicated issue. Dealing with these complications of oral hypoglycemics itself is a big issue which we may not be possible to deal with. It may not be possible to deal with the short duration. So I'll just give a very just sensitizing issue. That's all the issue. Then the and more of the complications is the insulin administration induced diabetes. Again, very common complications are hypoglycemia and insulin resistance. When the required dose of insulin is more than 150 units, that's considered as resistance. These days, we have multiple options. Again, this issue of selecting the right option of the insulin and fixing the dose of the insulin itself is a very elaborate issue, which I will not go into as such. But in these conditions, the management would be have to have a this regular assessment, proper assessment, and suitable administration of the insulin would be necessary if the patient is insulin dependent. No other choices. Insulin dependent diabetes, insulin has to be administered. Obesity is one more. Then local infections at the site of injection, which can be effectively managed to a certain extent by taking care of the hygiene and exercise lifestyle activities. Lipodystrophy, that's at the site of injection, there could be fat necrosis. And one of the major problem would be if the patient injects insulin at the same site repeatedly in the area where the fat is dystrophied, the rate of absorption of insulin would be varying. At times it will be rapidly absorbed, at times it may not be absorbed. Hence, even if you are giving the fixed glucose dose of insulin, patient's blood sugar level may fluctuate, producing lot of confusion. So, in such conditions, again, we will have to instruct the patient about selection of the right spot for the insulin injections. Of course, allergic reactions are common with any of these. Now, the in all diabetic patients, the most important guideline, which is mentioned by Ayurvedic textbook, the standard protocol, which would be very suitable and which is absolutely relevant even now or even after a few years, hundreds of years, like a Trikala Satya is a Matrashi Sarvakalam Chat, the Matrahi Agne Pravartika, Matram Dravyanapekshanti Gurunyapi Laghunyapi. If you have enough of food managed with the proper quantity and never overeat, the chances of diabetes is very significantly lesser. And the ideal suggestion for every patient who is diabetic or where you want to prevent diabetes would be same guideline given by Vagbhata. Gurunam ardhasahutyam laghunam nati truptala matra pramanam nidristam sukam yavad vijayati. The patient should not have overeating, never eating, and then the other guideline is annena kuksheha dvamsho panena ekam prapurayal ashrayam bhavanadinam chaturtham avasheshayat. Now, as far as the treatment protocol mentioned by Sushruta, again, which would be quite relevant, though it looks like a somewhat odd, would be to have that calorie balance. Now, one of the most this heated discussion in diabetes management is about the calorie intake and calorie balance, utilization, and so on. The same is mentioned by Sushruta as in case of a rich patient who cannot be just enforced with or enforced with the restrictions about lifestyle activity, exercise, etc. You give a food which will produce some this rather rather unacceptable taste, and because of the unacceptable taste, the food intake is reduced. That's like Ustra Ashwatara Purisha Churnani Asmita Ashanesh. Add the pieces of the animals which will have very low this low calorie content and deepana pachana aushadhi hingu saindava yuktaihi vishaihi sarshapescha ragaihi bhujayet and the total food intake has to be reduced. To reduce the total food intake, you may give any of the options. And the rigorous exercise, vayama, niyadha, krida, rajat, ragapatha. So the basic issue of management of diabetes is about the diet and exercise from Ayurvedic point of view. A very useful guideline, which is very suitable, universal, would be what Sushila has suggested. A patient who is having no resources, पादत्राण आसपत्र विरहितः भैक्ष्यासि ग्रामीकरात्रवासी मुनिरिव संयतात्मा योजनशतम् अधिकं वा गच्छेत् महाधनो वा श्यामा कन्नीवा वृत्तिः आमलक no, he has to walk a long distance. Now these days the fashion is about having apps in your mobile or maybe the specific instruments, the variables over the arm, where you count the steps you have taken. And what Sushil has said is you have to walk a long distance constantly every day. Gramaikaratravasi, never stay in a place for more than a night. And then Shama Kanivara Vrittihi, the diet should be mainly the substances which are having lesser calorie diet. Of course, the current fashion is what we call as millets. That millet has become a current fashion, which is already mentioned by Sushili in terms of the Shama Kanivara Vrittihi. Then Amalaka Kapita Tinduka Shanantaka Falahara Mrigi Savaseta. Satyam Anugrajal Gaha. Then Shila Unchavritti Bhuta Brahmaratham Uddharete. Shila Unchavritti is you collect the food which has fallen, the grains which have fallen from the field, pick up them yourselves and eat. Do not have to go for collection asset or Khanedwa coupon, digable or crucial. And if you follow these restrictions, the prameha can be controlled. Now, what the WHO recommends is the same, but in a sophisticated language, where you have to maintain a heavy this healthy body weight, physically active, 30 minutes of regular work, somewhat more decent presentation, looks like decent, but in core it is the same as such. Now, very funny, interesting is that WHO has given a guideline of exercise, and the most important is what they say is every move counts. So instead of using a remote, go and switch on or switch off the instrument. That's how the instrument starts. And there are some guidelines like how much of the time has to be utilized for the exercise as such. But I think this art would be very childish if you look at the guidelines given by some our samhitas which are eternal. With this, let me conclude. Concluding is lifestyle and diet modification is the most effective means of preventing the complications of diabetes. Incidence of complications of diabetes is a huge medical problem, and there is a significant role for hygienic management in such cases. And judicious use of our contemporary knowledge with the ancient wisdom will be really helping the suffering humanity. With this, let me conclude. Thank you for the occasion, and I hope there will be some feedback or questionnaire. Then we'll conclude. Thank you.
Thank you so much, sir. That was really an informative session.